Welcome everyone. This is Dr. Sharad Jaitley on my website, which is your favorite website as well, munimeterhealth.com. Welcome to this website, which is dedicated to teaching you about the human heart and its illnesses and its treatment modalities that we offer within the scope of our short video vignettes, which are being shown on Facebook and YouTube, your two favorite channels. Hopefully you're subscribed to both of them. Thank you again for this interest that's been growing across the globe and helping me in my endeavor of spreading this knowledge for freely to all. Thanks again. Welcome to munimeterhealth.com, your favorite website. Today I'm going to be discussing, without any further ado, let's get into the subject matter. As I always say, let's get into the subject, and the subject is today hibernation. What is hibernating myocardium and what is stunned myocardium, if you will. So there is a stunned myocardium and there is a hibernating myocardium. So these two terms have been coined for about now 2 decades or so, where people are starting to increasingly understand the level of myocardial ischemia. Again, remember, it's implying myocardial ischemia in all settings, but the very fact one is hibernating, the other is stunning, let's try to compare and contrast the two. What do we understand? Well, let's take, for example, if there is a chronic ischemia that's occurring. Say this was a normal blood flow, and gradually the blood flow was decreasing over a period of time, and then it was restored back to normal, and it was normal here. So that was the blood flow, that was the coronary blood flow in a setting of hibernation myocardium. Whereas the function will appear the following way, if you will. The function will also parallel the coronary blood flow. This is normal. Now here there is a decline in the function, if you will, and then as the blood flow is being restored, the function takes its own time to return back to normal. So this is the way in temporal relationship as to how the function, and the red being the systolic function, if you will, of the concerned segment, myocardial segment we're talking about, in a setting of hibernation, implying that there is chronic ischemia here as opposed to stunned, which we'll talk about in just a second. Now let's see what's going on in the stunned variety. You have a normal blood flow and a sudden occlusion that occurs in a setting of, say, an acute myocardial infarction. Now the blood flow stays like this for a length of time till the artery is open, and then the blood flow is returned back to normal. So that is the coronary blood flow in a temporal relationship shown in a setting of an acute ischemia, if you will. So remember, the ischemia that's occurring at this point is actually occurring in a setting where there is enough drop in blood flow and then restoration that's occurring here at this level, either from a revascularization or what have you, or a spontaneous thrombolysis. What happens to the function? The function in a setting of acute will show normal function here. Obviously this was a normal flow, and as soon as one sees a drop in the coronary blood flow, the segmental wall motion abnormality still persists for a while till it is way down up to this point. Now this is where the artery is being opened, and as soon as the revascularization occurs, this is restored again. So what have you seen the difference between the hibernating and stunned myocardium? In a chronic variety, both the systolic function and the coronary blood flow, they decline over a period of time to almost a minimal, till the arterial supply is restored here, and then the function takes its longer time for it to return. Whereas in a setting where the coronary blood flow was abruptly stopped, like in a setting where there was an acute myocardial infarction that occurs here, thrombosis, the heart function, the segmental wall motions will still persist for a longer period of time, like several hours or maybe a day or two, till they return back to normal after the acute revascularization has been offered in this setting here at this level. When the coronary blood flow is quickly restored, the function also returns back to normal, and in a shorter period of time, I would say, maybe in 2 to 3 weeks. Whereas here it takes longer period of time for the heart function to return. It takes longer period of time for the systolic function also to diminish because of chronicity of the ischemia. So clearly there is a compare and contrast between hibernating and stunned myocardium. Both are myocardial ischemic terms. One is chronic, the other is acute. One occurs in a setting where there is chronic CAD and multivessel disease. Acute myocardial infarction is recognized by an EKG, simple EKG, and then one can immediately do a coronary angiography, find out where the culprit artery is, and as soon as you can open up the artery here, you can offer a PCI or a CABG depending upon the level of obstruction, and mostly PCI is offered during the time when somebody's having a heart attack, but a CABG is offered in a very specific setting where the LV function is markedly down and patient is becoming hemodynamically unstable, or there is 2 or 3 vessel disease inculcated as well, then a CABG can be offered as well in an acute MI setting. So in a nutshell, revascularization helps quickly in a coronary blood flow, which is diminished rather quickly to a level of almost 0 in an acute myocardial infarction setting, whereas revascularization does benefit in a chronic blood flow reduction in a setting of hibernating myocardium, but only takes several weeks for it to return back to normal, both the function after restoring the blood flow in this setting here. So the coronary blood flow could be restored both by, again, PCI or CABG, depending upon. Now, very importantly, hibernating myocardium needs to be recognized because you need to ascertain that the myocardium has viability. If there is no viability, what is the sense in opening up an artery here when actually you're not going to gain anything out of it by contributing to the opening of the artery, because the function will not be restored. So you have to demonstrate the myocardial viability is very, very important in a hibernating myocardium, and so also in a stunned myocardium in a way, but you don't have to see it because here the temporal relationship is so short that it's a matter of few hours that the heart attack has occurred, because this being a very acute process, it's an acute MI. So if within hours one can restore, the blood flow here, you should be able to gain a good handle on myocardial segment improvement in terms of function over a period of time after you have opened up the artery. So it's very important that viability be assessed in a hibernating myocardium, and there are tests that are done. One is thallium 201, and we'll discuss that in a separate video vignette, but just remember thallium redistribution is one way, and of course the second is a cardiac PET scanning, where one can demonstrate that there is not myocardial necrosis, but there is myocardial viability available in certain segments which are showing dyskinesia or hypokinesia in a nuclear scan. Thank you again for watching MuniMeterHealth.com, your favorite website, which is dedicated to teaching you human heart care and its illnesses. Today we discuss hibernating versus stunned myocardium, if you will. Hibernating is a chronic process, stunned is an acute process. Both can be reversed by spontaneous thrombolysis or by offering revascularization in the form of PCI or CABG. And of course, myocardial viability must be demonstrated in the setting of hibernating myocardium before opening of the artery. It is crucial. Whereas in an acute myocardial infarction, the recognition is very easy because you know that the heart attack has occurred. It's a matter of only a few hours. Based on an EKG alone, you don't need to do any further testing other than a coronary angiography. That's where you'll demonstrate which artery is inculcated, and you can actually open that either by PCI or CABG, depending upon the coronary anatomy involvement. Thanks again. Keep watching MuniMeterHealth.com, your favorite website. Until then, so long. This is Dr. Sharad Jaitley.